Really, welcome to Secrets of Neurology, Knowledge Feast for Neurologists. Today is episode 35th, almost nearing third year. And this time we have a very interesting case presentation from Department of Neurology, from prestigious Govind Ballabh Pant Institute of Postgraduate Medical Education and Research, New Delhi. All this has been possible, this journey for last 3 years, courtesy the brainchild and excellent leadership by our course director, Dr. Sudhir Shah and Dr. Lakshmi Narasimhan. A warm welcome to Head of the Department of Neurology, Dr. Debashish Chaudhary, and his excellent team, and also to Dr. K. Vijayan. We intend to close this in another 1.5 hours. Dr. Sudhir Shah needs no introduction. Just to briefly summarize his excellent achievements, Professor and Head of Department, NHL MMC and SBPI MSR Ahmedabad, and Sir is also Director of Neuroscience at prestigious Sterling Hospital, Ahmedabad. Author of 6 books on neurology. Because of his work to society, patients, and research, Dr. Sudhir Shah also got conferred with prestigious Padam Shri. Sir is also recipient of BC Roy Award and recipient of Yona Award, and has appeared in many documentaries such as BBC and Discovery channels. Dr. Sudhir Shah's interest is into stroke, neurodegenerative disease, and epilepsy. Our second program director, equally having loads of accolades, Dr. Lakshmi Narasimhan Ranganathan Sir, Director and Professor, Institute of Neurology at prestigious Madras Medical College, the place where he started doing his DM. He is now heading the department. Many awards and affiliations, just to mention a few. Paltussi Advisor from AN, A.B. Baker Award from AN, Best Paper Award at AN, Global Elsevier Atlas Award, and his contribution to academics, both at the global and national platform, is amazing as well. Executive Committee member of World Federation of Neurology, and successfully organized 7 consecutive clinical neuroscience programs for All India DM postgraduate programs called SHINE. Thank you all, both our program directors. Warm welcome to you, and a warm welcome to our presenters today. May I request both our program directors to take it forward from here.
Hello. Dr. Manoj, thank you very much for those kind words. Am I audible?
Yes, sir. You are
Yes,
audible,
sir.
sir.
Yeah, sure. First of all, I must thank G.B. Pant Institute of Medical Sciences for accepting our invitation at a relatively short notice to present a wonderful case. And I'm sure all of us will have a great learning today. I'm also expressing my gratitude to my co-course director, Dr. Lakshmi Narasimhan, for helping me out, being a backbone of this wonderful web series. This is 35th episode has been told, and next month we will be completing 3rd glorious year, continuous, wonderfully arranged, highly successful, and maximum, I would say, appreciated series. And I must give enough credit to Dr. Lakshmi. Also, my thanks to the participants, delegates, and all previous presenters. Thank you for your warm support and interest. My thanks are also due to INTAS Global Cell Division, headed by Mr. Chadda, Dr. Manoj Kumar, and the team for logistics support. Today, we are having a case from G.B. Pant, as I mentioned, and the case presenter is Dr. Manju Yadav, the resident. Dr. Ayush Mohan is an assistant professor who is going to do clinical localization differential diagnosis. Radiology will be taken up by no less a person than Dr. Ashish Duggal. Summary and conclusion by most learned Dr. Devashish Chaudhary, the director of GB Pant. And interestingly, this time we have added one more learning session, and that is by Dr. K. Vijayan, sorry. What is all this fuss about? I'm sure smart guys out of you will make out what we'll be exactly discussing in this FUSS versus FUS. So may I have the slide run, please? So Manju is a senior resident at Govind Vallabh Pant Institute of Postgraduate Medical Education and Research, New Delhi. Next slide, please. Dr. Ayush Mohan is a DM neurologist, is assistant professor currently at GB Pant Institute of Postgraduate Medical Education and Research, New Delhi. Next slide, please. Dr. Ashish Duggal is an associate professor of neurology, currently has moved to BAVMS and the Dr. RML Hospital, New Delhi. Next slide, please. And what to say about our incoming president of IN, Dr. Devashish Chaudhary, my personal friend, who is a MBBS, DM Neurology, and Commonwealth Fellow, Director, Professor, and HOD of Neurology of GB Pant Institute of Postgraduate Medical Education Research, a very profound post, and also President-elect of Indian Academy of Neurology, President-elect Delhi Neurological Association. He's carried a lot of accolades, and I don't think I can read up them all, because what I have described is enough to mention his stature. However, to mention a few, they received multiple awards like Best Student Award. He was trained in good clinical practice at under Harvard Medical School, USA. He has also received Mohanlal Nair Award, Indira Gandhi Appreciation Award, Delhi State Award, and a lot of like distinguished eminent medical teacher award, etc., etc. He received a fellowship of Indian Medical Academy of Neurology, is a member of Education Committee, International Headache Society. He is the face of headache medicine in India. As you know, everywhere, whenever we discuss headache in India at least, and even abroad, we always remember Dr. Devashish Chaudhary for his work, his contribution, and is invited at all places for various lectures, including headache and others. He has published more than 200 articles, very voluminous work, and has chapters in international and national journals, books, and monographs. As you know, he has also created a epilepsy film, which is also widely circulated. We also saw it our place during Epilepsy Day seminars. He has edited and co-edited about 16 books, and he was the editor of Indian Clinical Update series on headache. And in 2018, he has been awarded prestigious Professor G. Arjun Das Oration Award by Institute of Neurology, Madras Medical College, and Professor Dr. B.C. Bansal and Dr. Uma Bansal Oration also. So just to mention a few things, more than that, he is a very amicable fellow, very great administrator, and as I mentioned, a very positive personality. Slide, please. So the case today is rapidly progressive dementia, and I'm sure this will be something extraordinary, and the discussion and localization would be also wonderful. After this case discussion, Professor Dr. K. Vijayan, consultant neurologist and neurosonologist at Royal Care Hospital, Coimbatore, would present something extraordinary. I think there's only one single machine in India, to my knowledge. So, he's the principal investigator, phase 3 trial of diabetic neuropathy, phase 3 trial of post-traumatic neuralgia, phase 3 trial of spasticity, and he has paper on idiopathic integral hypertension, participated in presented paper on ischemic stroke at World Congress of Neurology, and presented paper on vasculitic neuropathy. I'm not going to say what all this fuss is about, but I'm sure you have guessed it correctly. And with that, I once again thank all the participants, delegates, previous speakers, and current presenters. And with that, I request GB Pant team to take over. Dr. Ayush or Dr. Debashish, who is going to introduce the case presenter, or may I ask
So
directly the question?
I think we can start straight away. I request Dr. Manju to put on the slides and start the case.
All right, thank you.
Thank you.
Good evening, everyone. May I audible, sir?
Yes, ma'am.
Yes, you are audible. Please go ahead.
Good evening, everyone. Thank you again for providing this opportunity of presenting the case in Neurology Secrets. So we'll be starting with our patient. Chief presenting complaints, a 69 years old male patient, right-handed, graduated in BA Political Science, retired from government post in 2013, belonging to Delhi, presented with cognitive decline in form of forgetfulness and behavioral changes and difficulties in activity of daily life since 10 months and 2 episodes of acute onset dysarthria in last 2 months. Cognitive decline since 10 months. Patient was relatively asymptomatic before 10 months when he was doing well. He used to wake up around 7 a.m. in the morning, would carry out his daily activities on his own. He would read newspaper, which was his favorite hobby. And sometimes he would even help his wife in getting groceries from the shop and would manage all the family financial issues on his own. His wife then noticed that he was forgetting things, which initially was episodic and would occur occasionally. It gradually progressed over next 2 months so that it became difficult for him to recall what he had last evening for the dinner. He was now forgetting the things he was asked to get from the market as well. He would also forget things after keeping them in particular place. However, he was able to recall his important life events related to his education, marriage, and birth of his children. Soon he was finding it difficult to recall his friends' names whenever asked. Patient's wife also noticed some behavioral abnormalities in him. He became withdrawn. He was now losing interest in reading newspaper and would not care much of the relatives who used to see him and would not talk much to them. He was very fond of doing yoga every morning initially, but he stopped that altogether. Initially, he was very selective about his choice for the food, would never let anyone to waste food, and would ask wife to keep kitchen clean always. But now he would eat whatever served, and would often leave food behind in plate, and was not much bothered about dirty utensils in kitchen sink. There was no history of sadness, low mood, or early morning awakening or insomnia. Patient's wife also complained that earlier he was a very calm person, but now he was getting short-tempered and would easily get angry on silly things, though there is no history of getting abusive or any physical aggressiveness. Also, there was difficulty in managing daily activities. Though he was able to perform all his activities himself, he eventually started taking long time to complete his task. He would spend hours inside the washroom. He would return only when asked to open the door and come out. He would sometimes even return with half of the work done while bathing, and sometimes would wear his clothes wrongly. There was no obvious slowness in his motor activities. There is no history of difficulty in combing hairs, shaving, or eating. Also, initially, he was taking care of all financial decisions of his family. Eventually, he started making errors in managing financial calculations and would find it difficult to exchange money after buying groceries. Meanwhile, relatives consulted a neurologist for his complaint of forgetfulness, behavioral changes, and difficulty in carrying out daily activities, and MRI brain was done. Also, there's a history of 2 episodes of acute onset dysarthria in the last 2 months. Patient developed first episode of acute onset dysarthria after he woke up in morning 2 months back. He found out that he was not able to speak clearly. He was able to communicate meaning of his sentences, but words were not clear. There was also mild weakness and ataxia of left limb. These focal neurological deficits were short-lived. The patient was evaluated and treated in private for the same, and subsequently, as the cognitive dysfunction was progressing fast, he was referred to Dr. Debashish Chaudhary. While the patient was being invested during our hospital stay, on the day 7 of admission, he again developed second episode of acute onset dysarthria, and there was a further decline in cognition as he woke up in the morning. He became less responsive to the commands and seemed more apathic. His speech output further reduced and words were not clear. Though there was no difficulty in understanding the meaning of his sentences, no difficulty in repetition of simple words, there was no history suggestive of motor or sensory weakness this time, no history of vertigo, diplopia, dysphagia, or vomiting, and no history of headache or every abnormal movements. Also, there's no significant history of any significant fluctuations in daily basis, no history of inappropriate crying or laughing, no history of major urinary incontinence, no history suggestive of navigational difficulties or finding ways to kitchen or rooms inside the home. There is no history of difficulty in recognizing his relatives or people whom he was meeting regularly earlier. Also, there is no history of difficulty in appreciating colors. There was no history of blurring of vision, double vision, difficulty in chewing, difficulty in swallowing, facial asymmetry, or no history of any tingling or numbness. There was no history of any delusion, hallucination, or any other prominent neuropsychiatric symptoms. And there's no history of seizures. Also, there's no history of tremors, slowness of activity, stiffness in any part of the body. There was no history of any prolonged fever, joint pain, or joint swelling, no history of weight loss, no history of recurrent vomiting or loss of consciousness. Past history, there's a history of benign prostatic hypertension and surgery for the same in 2014. He was diagnosed as subclinical hypothyroidism and pre-diabetic 6 months back. There's no history of TB, hypertension, or any coronary artery disease in the past. Personal history, patient is vegetarian by diet. There's no history of any addiction. Sleep was not affected. Bowel, occasionally he used to have constipation. Bladder, as the patient was a case of BPH, so he was having some voiding issues. There was no history of any recent vaccination. And the drug history, patient was on thyroxine, 25 microgram, along with aspirin and atorvastatin. No significant family history. He has 2 children and he is one of the 10 siblings.
Thank
I
you so
would
much.
now allow Ayush sir to take over the next slides.
Thank you so much, Dr. Manju, for your case presentation. So I'll be sharing my screen. Are my slides visible?
Yes, sir.
Okay. So thank you so much, Dr. Manju. So continuing on the symptom analysis on the basis of history. So our patient had predominantly forgetfulness, apathy, behavioral changes predominantly affecting emotional circuits, that is anger, difficulty in carrying out daily activities, difficulty in managing finances, and 2 episodes of acute onset focal neurological deficits. So continuing the symptom analysis on the basis of history. So patient had forgetfulness, which was a predominant episodic memory loss, which could be localized to the Papez circuit. It refers to the system that actively holds pieces of transitory information in conscious awareness, where it can be subsequently manipulated or used to perform a task. So the Papez circuit involves the hippocampus, the fornix, the anterior thalamic nucleus, the anterior, the mammillothalamic tract, the anterior cingulate cortex, and the entorhinal cortex. So the second symptom, that is losing interest in previously pleasurable activities, that is apathy. This can be localized to the anterior cingulate circuit. The apathy can be defined as diminished motivation, not attributable to decreased level of consciousness, cognitive impairment, or emotional distress. Third symptom that the patient exhibited was behavioral changes, that is excessive anger outburst, which can be localized to the orbitofrontal cortex. Then difficulty in managing finances and daily activities. There was a lack of planning, which can be localized to the dorsolateral prefrontal cortex, and calculation abnormalities as well, as suggested by history, which can localize to the dominant parietal or the angular gyrus. Then there were 2 focal neurological episodes. The first one was the episode of acute onset dysarthria and ataxia, suggesting a stroke or a stroke-like episode involving the corticobulbar fibers in the internal capsule, or the cerebellum, cerebellar peduncle, and the brainstem. Similarly, the second episode of dysarthria, increase in apathy, is suggestive of a stroke or the stroke-like episode involving the corticobulbar fibers and the anterior cingulate circuit. So on the basis of the history, our syndromic diagnosis was a 69-year-old male without any significant comorbidities who presented with cognitive decline in the form of episodic memory impairment, apathy, behavioral changes, executive dysfunction, and 2 episodes of acute onset focal neurological deficits. So on the basis of history, since the history was very short and the patient was rapidly deteriorating, we had to keep a very wide differential diagnosis. Our first possibility was a vascular cause, and the other possibilities were a chronic infection, toxic metabolic causes, autoimmune or immune-mediated causes, neoplastic metastasis, and neurodegenerative causes as a brief overlay. I will be discussing the etiologies in the subsequent slide. So amongst the major etiological causes that we've mentioned, amongst vascular causes, we kept a possibility of a strategic or a multifocal stroke, and a CNS vasculitis and a cerebral amyloid angiopathy was also kept. And subdural hematoma, CVT, or a hereditary cause were less likely. Then secondly, in the chronic infections, a subacute chronic encephalitis, probably a fungal, viral, or TB had to be considered, and a hand-like presentation was less likely. Then in third, a toxic metabolic cause also had to be considered, as patient had a recent history of thyroid dysfunction as well. And since the patient was purely vegetarian, nutritional vitamin deficiencies also were considered, that is thiamine and cyanocobalamin deficiency. Then other causes which we considered were autoimmune inflammatory, autoimmune encephalitis, or steroid responsive encephalopathy associated with autoimmune thyroiditis. Keeping in view his age and the rapid progression of symptoms, a neoplastic or a metastatic cause also had to be considered. A primary CNS tumor or a CNS lymphoma, either a primary or secondary, or leptomeningeal carcinomatosis or metastasis to the CNS. Then finally, there was a possibility that maybe the subtle symptoms and signs which were initially present might have been missed, and the history was for a long period of time. So Alzheimer's disease and FTD phenotype also had to be ruled out. And in view of the rapid history, rapid progression of the symptoms, prion disease also had to be considered. So one by one, listing the possibilities, I would like to mention what was the points for and point against. So for the vascular causes, the point for were the patient had an acute to subacute onset and in view of the focality. Then why is it, what are the points against vascular causes is that the patient does not have any previous history of any vascular risk factors, and the cognitive decline had started before the stroke, and patient did not have any history of headache or seizures. Then for chronic infections, the points favor are that the patient again has a acute to subacute and a very rapid progression. But the points against are that the patient does not have any systemic symptoms of headache, fever, weight loss, any rash. Then similarly for toxic metabolic as well, we primarily considered it because the onset was again acute to subacute, and patient recently had been diagnosed with subclinical hypothyroidism. But the point against was patient did not again have any systemic manifestations of any endocrine or metabolic manifestations like weight loss, fluctuating course, any skin changes, any peripheral nerve involvement. Then for autoimmune or immune mediated causes, we primarily had to rule this out because again, the onset was very subacute and the progression was rapid. But patient did not have any frank encephalopathy, no systemic symptoms, restive or sarcoid, and no history of headache or seizures. So that was the point which was against. Then keeping in view his age, we had to keep a possibility of a neoplastic or a space occupying lesion. So the points in favor was age, the acute to subacute onset, and certain focality as well in terms of the symptoms. And again, the point against it was that the patient had despite patient having a very rapid progression, the patient did not have any signs, symptoms of raised ICT, no motor sensory weakness, no history of weight loss, headache, or systemic symptoms again. And finally, keeping in view the neurodegenerative disorders, as already mentioned, although early onset Alzheimer's can and certain other dementias can have a rapid progression, but patient was coming at a later age. But as already mentioned, that the earlier symptoms might have been missed. But again, the point against it is that the patient did not have any myoclonic jerks, any other neuropsychiatric manifestations, and the course, if at all, we go on the face value of the history, seemed very rapid. So I'll hand over the slide to Dr. Manju to continue forward with the examination.
So starting with the examination. In the general examination, patient was cooperative, lying comfortably in bed without any abnormal positioning. Vitals, blood pressure was 130/90 in both the upper limbs. Pulse rate was 88 per minute, regular. In the cardiovascular, respiratory system was normal. There was no carotid brew. The neurological examination, patient was not oriented to person and place, and the release reflexes were present. In the higher mental functions, the MMSE score was 7 out of 30, MoCA score was 4 out of 30, and FAB was 7 out of 18. In the MMSE score, that he scored 7 out of 30, the main points that he lost were in the orientation. Registration was, though he was able to register. Attention and calculations was also, he scored 0 out of 5. Recall also was 0 out of 3. And among the copying also, he couldn't copy, it was 0 out of 1. And in the MoCA score as well, the mainly affected domains were naming, memory, and attention, also the language. In the clock drawing test, the size of the clock that he had drawn was normal, and the clock was circle, and the numbering was done from 12 to 1 to 12, but there was inappropriate spacing, that there was overcrowding, and there was overcrowding somewhere and overspacing over the right hand side, mostly suggesting the planning and special deficits. Also, when asked, he failed to put arms in the clock, so there must be some conceptual deficit. In the Necker cube and overlapping pentagon drawing test, there was over intersection of the lines, and the patient was not able to complete the lines in the below figure, possibly suggestive of difficulty in some planning or copying. While testing for the complex attention, sustained attention was impaired as the forward digit span was 3 and backward digit span was 0. In the selective attention was also impaired. In the vigilance test, there were 3 omissions, 4 commissions, and there was no perseverance. While testing for the executive function, patient failed alone while performing the motor Luria test, but he performed 3 consecutive correct with the examiner. In the graphic Luria test, he failed to follow the pattern. In the conflicting instructions, patient performed 1 to 2 errors. In the go-no-go test, he performed more than 2 errors. And in the trail A, trail B test, he was not able to do. And the letter fluency was also impaired. He barely could speak 2 or 3 words. While the FAB test in the frontal assessment battery, he could score only 7 out of 18. While the testing for learning and memory, the recent memory or the episodic memory was impaired. He could name only country. And the remote memory, he could recall around 50% of the events correctly. In the Liu learning ability, registration was normal and recall was impaired. Visual memory was also impaired. And the semantic verbal influency, he could say only 4 words. While testing for the language, spontaneous speech was reduced. There was reduced fluency. There was reduced letter and semantic fluency as well, though there was no paraphrasias, any neologism. While auditory comprehension, his pointing commands, he was doing well. Yes, no commands was 6 out of 7. And the complex questions, he scored 1 out of 2. Repetition, he could repeat simple commands up to 3 words. Naming and word finding was impaired. In the reading, he can read, but there was difficulty reading the difficult words. And writing, the spontaneous writing was impaired, while the dictation and copying was normal. While checking for perceptual motor function, neglect, simultagnosia was absent, apraxia was absent. There was constructional abnormality was there, and calculation was also impaired, and the right-left orientation was maintained. While examining the cranial nerves, cranial nerve 1, 2 was normal, fundus was normal. Both the pupils were equal reacting to light. Cranial nerves 3, 4, and 6 were also normal. Cranial nerves 5, 7, 8, and 9, 10 were also normal, and 12 was also normal. In the motor examination, bulk was normal bilaterally. Tone was increased in both lower limbs. Power in the shoulder, elbow, wrist, and small muscles of the hand, it was 4/5, though he had weak grip bilaterally. While examining the lower limb, hip, knee, and ankle, the power was 4/5 on the right-hand side and somewhat low compared to right over the left-hand side. The deep tendon reflexes were brisk bilaterally in biceps, supinator jerk, triceps, and knee. And the plantars were bilateral downgoing. While the sensory examination and extrapyramidal examination was normal, cerebellar examination, though patient was having dysdiadochokinesia bilaterally. Hill-Shin also was positive. Finger nose test was negative. Patient was slow in gait. He had reduced ground clearance and meningeal signs were absent. So after history and examination, probable localization, the brain involvement is dysfunction of frontal lobes, predominantly prefrontal, temporal, and non-dominant parietal with preserved occipital lobe functions. And in motor examination, bilateral brisk reflexes were there, but no other focal deficit was there, and the release reflexes were present. So considering all the above features, it favors global involvement of brain and possible corticospinal tracts bilaterally. So considering all the possible differentials as discussed earlier, patient was investigated. In the routine investigations, we found out that ESR was 80 and CRP was positive. His HbA1c also came out to be 7.2. Apart from this, all routine investigations in the hemoglobin, renal function test, and liver function tests were normal. His TSH was 9.4 and the anti-DPO antibody was negative. His entire autoimmune profile, including paraneoplastic panel ANA, were also negative. His ANCA and C-ANCA and P-ANCA was also negative. And we also went for CSF, which was also normal. Next, the neuroimaging. I request Dr. Ashish sir to kindly take over the neuroimaging part.
Yeah, thank you, Dr. Manju, for discussing the clinical history examination. So I will be discussing the radiology part. And in this patient with rapidly progressive cognitive decline, probably the answer for his problems is going to come from the radiology, because most of these investigations were essentially did not reveal anything much. So we came to us with this MRI, which was done in September 2022. This was done because his attendants were worried about his cognitive decline for the last few months. And this MRI, basically, this diffusion images show multiple so multiple infarcts in different territories. There are infarcts in the posterior occipital lobes and then the frontal lobes by both sides. So there are multiple infarcts in all the three territories, vascular territories, which some of them even showing hypointensity on the apparent on the diffusion on the ADC maps. So there were multiple infarcts at that time, and the SWI images revealed multiple microbleeds. Now these might not only in the thalamic region but also in the cortical region. Rather, cortical microbleeds were much more prominent than the subcortical microbleeds. So there were microbleeds in the temporal lobe, in the sensory motor cortices, in the occipital lobes, in the frontal lobes. There were multiple microbleeds which were seen. And on the T2 FLAIR images, there were white matter hyperintensities. They were sort of mild asymmetry was there. There was some hyperintensities in the posteriorly, but these hyperintensities were reaching up to the immediate subcortical matter, to almost to the reaching up to the cortex, as can be seen here. They were diffuse white matter hyperintensities, and even in the frontal lobes. And on T1 imaging with contrast, there was no none of these lesions were taking any contrast, so there was no contrast enhancement. Though there was some T1 hyperintensities in the lesions which were showing T2 and FLAIR hyperintensities. I'd like to point out this image. So there was a frontal lobe hyperintensity, and surrounding that there is a frontal lobe microhemorrhage, a small microbleed, but there is a significant amount of white matter involvement surrounding that microbleed, sort of edematous, and this was seen in the frontal lobes. A CT angio was also done at that time, considering that he had multiple infarcts. He was evaluated at that time outside. The CT angio showed only a mild atherosclerotic changes in the bilateral carotid bulbs with mild tortuous cervical segment of the bilateral ICS, which was not much significant. So no cause for this diffusion-weighted imaging was found. And now later in March, he developed an acute onset of dysarthria and ataxia. So an MRI was again repeated. Now this shows another acute infarct in the pons and on the left corona radiata. And now those earlier the diffusion weighted images hyperintensities are not visible here in this image. Although the microbleeds are still present, there is a new microbleed in the pons, another one, and other microbleeds are also present. Though the microbleeds may look to be less as compared to the previous film, but this is a GRE image and the earlier one was a SWI image. So that is more sensitive to picking up at microbleeds. So there were still microbleeds which were present in the cortical areas as well as the subcortical areas. And again, so after this, another MRI was done when he was admitted in GB Pant and had developed an acute onset of dysarthria. This was done in May 2023. Again, he has had fresh infarcts. This is an infarct in the thalamic area in the internal capsule, which is showing hyperintensity on ADC maps. and new microbleeds in the thalamic area. There is a thalamic hemorrhage here. And there are multiple microbleeds again in the temporal lobes, in the frontal lobes, the sensory motor cortices. And I don't know if it's visible, but I marked an arrow here, and there is probably a cortical superficial siderosis here. There is a hemorrhagic GRE image, GRE hypointensity in the sulci. Probably a cortical superficial siderosis present here. So on the T2 FLAIR images, again, there were multiple white matter hyperintensities, some of them reaching up to the cortex, subcortical, immediate subcortical area, in the frontal lobe, in the frontal lobe here, and in the parietal lobe also. So basically, this patient had multiple hypointense foci on GRE and SWI and confluent white matter hyperintensities. So this slide basically shows the differential diagnosis for multiple hypointense foci on GRE or SWI. And most common are chronic hypertension and cerebral amyloid angiopathy and a traumatic axonal injury and metastasis. Then there are certain other less common causes, and particularly more importantly, a small vessel infarction occurring because of vasculitis or a vasculopathy, genetic vasculopathies like CADASIL. And confluent white matter hyperintensities, again, the most common cause is chronic hypertensive encephalopathy, but it can also be seen in cerebral amyloid disease, arteriosclerosis, multi-infarct dementia. And then there are less common causes like HIV and all, CADASIL, ADEM, and again, vasculitis, which is an important cause here. Rare but important causes include lymphoma, primary CNS lymphoma or intravascular lymphoma, angiocentric, which is also a possibility in our case, but particularly because of his old age. So the two broad differentials which are being considered in this case, because we have already done a lot of investigations, all of them were negative, the CSF was normal, and there were no other autoimmune markers were all negative. So in the main differentials were whether this is a cerebral amyloid angiopathy or a vasculitis or an arteriosclerotic vasculopathy. So microbleeds can be seen in both these conditions, in vasculitis, cerebropathy, as well as arteriosclerosis. But then there are certain subtle differences. So in cerebral amyloid angiopathy, we get a lobar ICH, we get a cortical superficial siderosis, as was seen in our patient. And then there is posterior white matter hyperintensities with multiple spots. So these are the posterior white matter hyperintensities and multiple spots in the cerebral hemisphere, as was seen in our case also. On the other hand, in arteriosclerosis, there are deep ICH, deep lacunes, and white matter hyperintensities are around the basal ganglia, and enlarged perivascular spaces also occur around the basal ganglia. So the imaging overall is more suggestive of amyloid angiopathy rather than an arteriosclerosis, though another possibility would be CNS vasculitis. So these are the different diagnostic criteria that have recently been published in Lancet in 2002. They have revised the Boston diagnostic criteria for cerebral amyloid angiopathy. And now they have given weightage to white matter lesions as well. Earlier, the criteria only had considered hemorrhagic lesions, but now they have found that ischemic lesions can also occur in cerebral amyloid angiopathy. And in our case, we found that there were 2 or more lobar hemorrhagic lesions on susceptibility weighted imaging. This patient had CMBs and one cortical area of cortical superficial siderosis. So probably age was more than 50 years. So he was probably having probable CIA. Another differential diagnosis could be that this could be a lymphoma, particularly an intravascular lymphoma. But usually there would be contrast enhancement. SWI imaging would be usually normal. There would be some associated symptoms. So these were the points which favored that this was probably some vasculitis, probably a CARI. And obviously one condition could be PRES. It could also present with white matter hyperintensities, but that is predominantly the posterior areas. But it could sometimes even be in the frontal areas. But there should be a trigger also, which was not present. And there is significant vasogenic edema and mark effect, which was not present. And microbleeds could be there in PRES, but not so many microbleeds as was seen in this case. So another close differential is CNS vasculitis, and it basically it will sometimes very difficult on basis of imaging to differentiate between CNS vasculitis and cerebral amyloid angiopathy related inflammation. Basically, in Kari, pathologically, what is happening is that there is amyloid deposition and antibodies are developing against amyloid and causing a perivascular inflammation. So if amyloid is absent and there is perivascular and vascular inflammation, then that becomes CNS vasculitis. So imaging may not help here, but CNS vasculitis is more commonly seen in younger patients, but Kari is seen in more commonly in older patients. Mean age being 67 years, our patient was an older one. Spinal cord involvement is seen in CNS vasculitis and not in Kari because amyloid is not present in the vessels in the spinal cord. And some, not always, but sometimes angiography may reveal multifocal stenosis in the medium-sized vessels. But Kari being a small vessel involvement, angiography is usually unremarkable. And one a new imaging modality that can help is amyloid PET. And this was reported that in patients with cerebral amyloid angiopathy related inflammation, there is increased amyloid deposition in the vessels, which are areas which are showing microhemorrhages, indicating that there is more amyloid deposition there, which is probably causing amyloid angiopathy. So another differential is whether this is CAA with inflammation or CAA without inflammation. So in CAA with inflammation, there are usually large, patchy or confluent T2 hyperintense lesions which extend through the subcortical white matter. Maybe, and there could be involvement of the cortical gray matter also. Then, but however, without inflammation, there is more symmetric or scattered subcortical white matter T2 hyperintense lesions. In CAA with inflammation, the lesions have significant hyperintensity on the corresponding T1 images. But in without inflammation, there is little T1 hyperintensity in the lesions. And in CAA with inflammation, the lesions are usually asymmetric. And if they are more symmetrical, then it implies that there is the CAA is without inflammation. So why are we thinking of Kari here? Because these were the diagnostic criteria which were published in 2016. And they require that the age should be more than 4 years. Then patient should have either one of the following, that is headache, decreased consciousness, behavioral change, or focal neurological signs and seizures. So our patient had a behavioral change, and the presentation should not be attributable to an acute ICH. So this initial behavioral change and all was not attributable to acute ICH. Then for our diagnosis of probable CARI, the MRI should show unifocal or multifocal white matter, cortical, subcortical, or deep. So there should be asymmetric unifocal or multifocal white matter hyperintensity lesions, which extend to the immediate subcortical white matter. So they should go right up to the immediate subcortical white matter. And then there should be hemorrhagic manifestations of cerebral amyloid angiopathy, and you should rule out neoplastic, infectious, or other causes. So this is how we diagnose the probable CRA. But then there is an entity there. The authors have also described that there could be possible CARI when the lesions are not exactly asymmetrical. There is some symmetry, but the lesions extend up to the immediate subcortical white matter. So all other things being same, if the lesions are extending to the immediate subcortical white matter, as seen in this case, we can consider a possibility of possible CAA-related inflammation. Obviously, we have to rule out neoplastic, infectious, or other causes. And I believe we had fairly evaluated the patient and ruled out most of the causes which could have caused this kind of presentation. So this patient was a patient with rapidly progressive cognitive decline and frequent focal neurological deficits. There were multiple infarcts, multiple microbleeds, white entities. Some of them were reaching up to the immediate subcortical white matter. So there obviously the possibilities were CNS vasculitis and CARI. Because this is old age, and we basically kept the first possibility as CARI, but we did other investigations. So we did a vessel wall imaging and of the intracranial vessels. We also did a DSA, both of which were normal. And to rule out a malignancy, a whole body PET CT was also done, which did not reveal anything and was also normal. So considering all this, we made a final diagnosis of possible cerebral amyloid angiopathy related inflammation. So this is not of this patient. This is an earlier patient which we had seen. And in this, you can see that there is significant white matter asymmetric hyperintensities, which are reaching up to the subcortical area. And in the FLAIR sequences also, you can see that there is significant white matter hyperintensities, vasogenic edema, some of them even extending up to the up to the subcortical white matter. And the GRE images showed multiple microbleeds all across in one lobar hemorrhage also, two lobar hemorrhages in fact. So this was a patient which had, which would fall into probable CARI rather than possible CARI. This was an earlier case which we had seen, and had this patient was given steroids and had improved. The hyperintensities had almost vanished. So this was these slides were to show you the difference between what is a probable CARI and what is a possible CARI. So that's it. I will now pass on to Dr. Ayush, who will discuss the treatment part of this patient and briefly discuss this about the CARI. Dr. Ayush.
Thank you so much, sir, for the extensive discussion, radiological discussion, and beautifully guiding us to the diagnosis. So are my slides visible?
Yeah, Ayush.
Yes, sir. Thank you, sir. So coming on to the treatment part, so finally we reached the patient as a diagnosis of a possible CARI. So patient was started on 5 days IV methylprednisolone pulse. Initially, he developed hyperglycemic complications due to IV MPS pulse, which were managed conservatively by oral hypoglycemic agents and insulin as well. And after 5 days of methylprednisolone, within a few days, around 7 days later, patient started showing significant improvement in dysarthria and general and mental functions, and patient seemed more well-oriented to time, place, and person. The MMSE was repeated, which was 13, which was a 6-point improvement as compared to before, and MOCA was 9, which was a 5-point improvement as compared to before. So in view of the nature of the disease, patients were explained about the possible role of immunosuppressants in CARI. So after ruling out any immunocompromised state and infection, patient was given first dose of cyclophosphamide along with low-dose steroids. Patient was discharged with, subsequently, patient was discharged with 30 milligram prednisolone, and currently he is doing well. There has been no further deterioration, and subsequently his general cognitive functions have improved also. Patient is now due for a follow-up assessment for a formal testing as well. So this was our clinical case. So I would like to thank Dr. Manju for presenting this beautiful case, and Dr. Ashish sir as well for the extensive radiological discussion. So I would like to share some brief slides about the theoretical aspects of the disease. So CARI, cerebral amyloid angiopathy related inflammation. It's an unknown amongst the knowns. A lot of things are known, but a lot of things are unknown as well amongst all the entities which we have discussed. So cerebral amyloid angiopathy is a small vessel disease which is characterized by deposition of amyloid beta in the media and adventitia of small and medium-sized vessels of the cortical and the leptomeninges. So cerebral amyloid angiopathy usually presents with a symptomatic acute lobar ICH. It is the second most common form of most common reason of spontaneous ICH, and it may present with or a chronic progressive cognitive decline and a very characteristic episode known as amyloid spell, which is a transient focal neurological episodes. So CARI, that is cerebral amyloid angiopathy related inflammation. It is an aggressive subtype of cerebral amyloid angiopathy. It can have much more diverse clinical presentations, but the radiological findings, as discussed by Dr. Ashish, are usually very characteristic. So the presentation of CARI is usually more acute or subacute, and it might be in the form of a cognitive decline or behavioral changes. The pathology is characterized by, similar to CEA, deposition of amyloid beta. And as it's an inflammatory disorder, due to the deposition of amyloid beta in the vessels, there is pronounced perivascular or transmural inflammatory infiltration. So the CARI subtypes theoretically is divided into two, and which can be sometimes correlated in imaging as well. So one is the non-destructive perivascular inflammation, which is known as the inflammatory cerebral amyloid angiopathy. And the other is ABRA, amyloid beta related angiitis, in which there is characteristically transmural intramural inflammation. So this is a diagram which is summarizing the continuum along in the CEA, the inflammatory CEA, ABRA, and the primary angiitis of nervous system. So these small curved lines are the amyloid deposits. So in CA, we can see that there is amyloid deposits in the walls of the vessel, but there is no inflammation. Whereas in inflammatory CEA, there is deposition of amyloid in the walls of the vessels, and there is vasculitis, the inflammation along the vessels, not in the vessels. Whereas ABRA is characterized by transmural inflammation. That is, there is amyloid deposition. Along with that, there is inflammation in and along the vessels. Whereas in primary angiitis of CNS, there is no definitive trigger, but there is transmural or perivascular inflammation, as we very well know. So this is another diagram which is summarizing the disease pathology and the location of the inflammation. So there are three hypotheses regarding CARI. Two hypotheses which are less accepted are, first is saying that the inflammation and the amyloid beta deposition is just a coexistence, just a chance existence, and there is no relationship amongst them. The second is that the inflammation, due to some unknown reason, leads to accumulation of amyloid beta in the vessel wall. But the most accepted hypothesis is that the amyloid beta deposition triggers the inflammatory response. And the evidence for that has come from the trials of the Alzheimer's disease antibodies. So clinical trial of monoclonal antibodies for AD led to certain imaging abnormalities known as amyloid-related imaging abnormalities, ARIA. So these were seen to be very similar to CARI. So, and there was a dose-response relationship between the therapeutic antibody and the severity of both clinically and radiologically, suggesting that the immune response is secondary to the amyloid beta. Thus, it has led to the conclusion that CARI is probably a spontaneous ARIA, whereas ARIA is considered to be iatrogenic CARI. So this is one descriptive MRI imaging showing the two spectrums of ARIA. The one is ARI hemorrhagic manifestations, in which microhemorrhages can be seen, and the distribution again is usually cortical. And this is the ARIA edematous variant, as we can say, in which multifocal parenchymal edema can be seen with viral swelling in the flare images. So these findings are very similar to the radiological findings which we've seen in CARI. So a brief description on the clinical features. So as already mentioned, this is usually seen in much more elder population as compared to CNS vasculitis. The average age of diagnosis is usually in the 7th decade. The major clinical manifestations are a subacute mental disorder and behavioral or cognitive changes, which is most common, as in our case, and episodes of focal neurological deficits. And headache and seizures also commonly seen. Rare manifestations have been reported in the literature, including involuntary movement, Parkinsonism, cerebral herniation caused by severe edema, and extracranial vasculitis as well. So Sir has had an extensive discussion on the radiology, but I would like to mention a few points about other investigations as well. So blood tests are consistent with signs of inflammation. The ESR is elevated in around 1/3 of the population, and the CRP is elevated around 60% of the population. There are certain case reports which have suggested a persistent elevation of P ANCA, possibly implying an association. And one thing which has been consistently seen, which is common to CAA as well, is the ApoE4 allele, which is the only confirmed risk factor for CARI, accounting for at least almost 3/4 of patients. There have been investigation into certain CSF markers as well. So increased CSF protein and pleocytosis is seen in around 80% patients and around half the patients respectively. And CSF amyloid beta autoantibodies have also been seen to be increased during the acute phase, and the antibodies level decrease after the corticosteroid use, which suggests a possible use as a biomarker. And consistent with the CAA, low levels of amyloid beta 42 and amyloid beta 40 are also found in CARI. So as already discussed by Dr. Ashish as well, that and there is an up and coming role for amyloid PET in cases where there's a diagnostic uncertainty. So this was the diagnostic criteria, the modification by Oriel et al., published in JAMA in 2016. So the main clinical features, as already discussed, were age more than 40 years, clinical symptoms such as headache or decrease in consciousness, which usually are acute to subacute, but can occur over longer timeframes as well. So asymmetric or symmetric white matter hyperintensity pattern extending to the immediately subcortical white matter, and presence of at least one of cerebral macrobleeds, microbleeds, or cortical superficial cirrhosis, and absence of neoplastic, infectious, or other causes. So this is for probable carry. So one thing which we were not able to do in this case, and one thing which is probably the most conclusive, is the histopathological confirmation. But as we very well know, that CNS biopsy is invasive, and as this is a multifocal process, the yield can be surprisingly low at times. So it is recommended that brain biopsy should be performed from an area with abnormal radiological manifestations, preferably at a lesion in the cortex or leptomeninges. But biopsy, as already discussed, can be negative because of the segmental distribution of the pathological changes. So coming on to the treatment and prognosis. So this is a very rare syndrome, rare disease. So whatever is described in literature is mostly on anecdotal evidence, and there are no formal guidelines. So empirical treatment is usually given with high-dose corticosteroids, which improves the symptoms and both imaging abnormalities as well, and improves the prognosis both immediately in terms of symptoms and in long term as well. Immunosuppressants should be considered in certain cases, especially for preventing recurrence. And also if there is no response to glucocorticoids. And improvement is usually seen in around 3/4 of the cases. And most patients, like in our case as well, respond within few weeks, although the improvement can be variable. So the most commonly used immunosuppressants is cyclophosphamide. Other agents which have been described include azathioprine, mycophenolate mofetil, methotrexate, and IVIG as well. So as already mentioned, there are no guidelines or study comparing head-to-head treatment, dosage, and duration of treatment. So treatment has to be individualized for each case, depending on the severity and the relapse. So this was a brief discussion over the carry. So I would like to mention certain take-home messages. So in an older population with a rapidly progressive cognitive decline associated with headache, seizures, or focal deficits, with MRI findings consistent with a carry-like presentation, like that is T2 flare hyperintensity, evidence of cortical micro or macro bleeds, or cortical superficial cirrhosis, carry should be suspected. But carry is a diagnosis of exclusion. Usually other differentials have to be ruled out. One point which Ashish sir also specifically stressed upon is that metastasis and CNS lymphoma is a common mimic. So that has to be very extensively ruled out, and we should be sure about the same. So as I've briefly mentioned, genotype studies, CSF biomarkers, and amyloid PET may have a role in helping in the diagnosis in the future. And high-dose steroids plus minus immunosuppressants help in improving the outcome and preventing relapse. So there are certain unaddressed questions since this is a rare disorder. So it is not clear why. So CA is a very common entity. And as discussed, it is the second most common cause of spontaneous lobar ICH, but only a few people develop this inflammatory form of CA. So the reason of the same are not clear, that why only a small proportion of patients develop inflammation. There is a need for further investigations, biomarkers, which can help us refine the diagnostic criteria and improve both the sensitivity and specificity, especially in differentiating from CNS vasculitis at times, which is a close differential. And further studies are needed regarding the optimal treatment, the immunosuppressant drugs, dose, and duration. So with these, I would like to, if Devashi sir is there, maybe he can conclude, or
Yes, I am here.
yes, sir. Thank you so much for joining, sir.
No, I have joined. I've been through and through listening to you also. Don't worry.
Yes, sir. Thank you, sir.
Dr. Shah is there and Lakshmi are there.
I am here, dear.
So, sir, first your comments on the case and the discussion, the way this has been brought out. Yours and Lakshmi.
Thank you very much. Dr. Lakshmi, you want to put comments first or shall I? Okay, so this was really a wonderful case, and I do remember we had a exactly similar case from Rajasthan, and we could diagnose this antemortem. Unfortunately, we lost the patient within 6 months, despite proper immunosuppression. Somehow there were a lot of other comorbidities. We should keep in mind the possibility of CARI in the subgroup of amyloid disorders, and this is one of the most severe forms. I do agree, and it has been very eloquently highlighted right from case history to analysis of symptoms to examination finding and radiology, and then proper information about the condition. I think we must all applaud the whole team. The question that comes to my mind is, what is the relation between Alzheimer's disease and amyloid angiopathy, and particularly CARI, if at all? And is there any report from geneticians regarding the predilection of the condition or any link between this disease and any gene? Could you come across any such literature? I agree that
No.
are very rare cases. And another thing, before I asked Dr. Devashish to comment, is in all cases of dementia, we must do proper MRI evaluation, including, of course, diffusion sequences, gradient sequences, SPINICO, and of course, SWI, etc. These are very important sequences. Otherwise, all those microhemorrhages and some other conditions can be missed. So whenever we see a case of dementia, we should ask full dementia protocol. I hope, I'm sure Dr. Devashish will agree. And Dr. Lakshmi, you have some comments, and then Dr. Devashish can take over. Yeah.
Professor Devashish, thank
Right.
you. Thank you for a wonderful case. We really enjoyed it. And, the moment GB Pant and Devashish and all, the whole country expects a lot of, and you have lived up to the expectation. The entire team presented a wonderful case, and I'm sure that it is everybody would agree with me that this is an intellectual feast for all of us. And the entity CARI and the inflammatory ECA beautifully covered, and the imaging part also excellently discussed. My congratulations to Ayush and Manju and Ashish Digal. Excellent, very excellent. And one important point also, he stressed that whenever you have a episodic stereotypic event, it's just not the TIA or seizure, any focal event. Amyloid spells have to be kept in mind. This is one of the important take-home message. If these patients present with stereotypic episodic, especially sensory, and almost like it's invariably, you should entertain amyloid spells also. And over to Devashish, we are looking forward to hear from you. And wonderful case. I must say, really, my hearty thanks to all of you. And
Thank
also
you.
looking forward to Vijayan, who is going to really make. In fact, I went to see Professor Vijayan's show there personally. I was amazed, and I'm sure that the entire country is looking forward to his presentation. Thank you.
Right. So I will not come in the way between Dr. Vijayan's presentation and not take much time. So just few comments. One is this, that of course, thanks for giving us this opportunity to present. And it has been actually a occasion that, because you insisted so much that we should present. So this patient came some time back, and actually this patient is the father of one of my occupational physiotherapists. So she was in tears and she said, "Okay, this my father is deteriorating so fast and nobody is able to understand, and he is having this recurrent strokes and as well as this cognitive decline. So kindly do something." So that was the moment where we started looking at this patient and totally thoroughly investigated, and then came up with that treatment plan. And fortunately, he has done well so far. So that is number one, that as you said that, whenever you have this kind of stroke-like presentation in a dementia setting and the dementia is rapidly progressing, so this is one condition which is treatable. So this is an important message to all the young neurologists who are attending this, that this is a treatable dementia condition which needs to be identified and treated. That is number one. Secondly, this case also prompted us to read more, because so much thing is happening, all these subdivisions,
Yes.
and the CA without inflammation, the CA with inflammation, then the various types. How do you differentiate it from the primary CNS angiitis? So it gave us an opportunity to read, and in fact, the presentation which Ayush presented, largely this has been presented by Manju. I told her to, you present in one seminar for this. So she prepared all this, data she collected and presented. So that stimulated all the residents also and us also as a faculty to learn more about this and be up to date about it. Right. So this is the second thing which I wanted to convey.
And you also passed it on to the entire country. And
yeah.
We are very happy.
That was the purpose. That was a purpose,
And a lot of overseas people also, they attend to this. In fact, one of our senior alumni from our institute, Dr. Arun, he has rescheduled his timing in US OP. It is 8:30 is his OP time. To attend this on Fridays, he has shifted his OP to 9:30.
Oh.
And he has sent us a message and compliments for this neurological secrets. And every presentation in this neurological secrets is a crown. And you have added one more jewel to the crown. Thank you.
Right. And finally, I would like to elaborate slightly on that radiological thing. Much has been made about this asymmetrical white matter hyperintensities. So the basic purpose of defining that criteria was this, but because in a lot of Alzheimer's disease or amyloid angiopathic conditions, you can get periventricular leukoariotic changes, grade 2, grade 3, and at times it becomes difficult to know that whether these were present from the beginning or this has come up. Most of these lesions which come up due to the inflammation are usually fluffy, edematous, and if they are asymmetric, they point more towards a new onset edematous lesion, and therefore that needs to be taken into consideration. But it does not mean that if you have a bilateral lesion or multiple lesions, there are hordes of images. Mostly these are presented as anecdotal cases or case series in the international journals. So if you go through them, you will find that many variations of the theme are there. So you should be open-minded. You should not just stick to that idea that it has to be always asymmetrical, always going from the subcortex to the periventricular to the subcortical area. There might be a lot of variations. There are thalamic lesions, there are frontal lesions, there are parietal lesions, so all have been described. So I will encourage all the youngsters, please go through this and read the recent reviews about this, and I think you can take on, and because if such patients come, then you have a treatable entity in your hand. And finally, I thank Dr. Manju, Dr. Ayush and Dr. Ashish for doing a wonderful job. And I know that they are good, and I know that in future also will be kind of coming up with new interesting cases. And I think from the neurological perspective, that neurology has changed. Neurology is now, a lot of neurological disorders are now eminently treatable. Whenever you go out, you say, neurology, what do? You don't have treatment. But no, that has changed completely. You have lots and lots of diseases to be treated. So all the young neurologists should know this, that they should be perfect in diagnosing these diseases and to know the nuances of these treatments. That is very important, the nuances of neurological disease treatment. And that was the purpose, one of the purposes of presenting this case, because now we have a treatment in hand. Thank you very much.
Thank you. I'll take up the question and answer sessions at the end of the talk of Professor Vijayan. Over to
Okay.
Professor Vijayan, over to you. Yep.
How do we put this presentation now?
So where is the same MRG?
In the desktop.
It go sir, show all. Advanced.
Right.
Just my.
Yeah.
Presentation.
This one.
Okay.
Click on.
Yeah. And share screens with this.
Are you able to see the screen, please? Am I?
Yeah, you are audible, but the presentation is not there.
Just a minute. Yeah, 1 minute.
Yes. Screen. No, yes.
Is it visible now, sir?
Yes, sir. Now it's visible. You can go with the full screen.
Yeah. Is it visible now, sir?
Yeah, sir. It's perfectly all right. You can go ahead.
First of all, my respects to Professor Sudhir Shah, Professor Debashish, and my thanks a million, Professor Lakshmi Narasimhan, for having given me this opportunity to present this small step of ours towards taking Parkinson's disease treatment into the future. Dear comrades, it's a great pleasure to present to all of you today. And this was a team that did the first MRI guided focused ultrasound treatment for Parkinson's disease. And seated there are Professor K. Srinivasan, who's our mentor and who's our one of the senior most professors, who also taught us about stereotactic telemotomy during the first procedure. Professor Mehendirata was very kind enough to come in from Delhi, and he also taught us extensively during the first case, and also during the inaugural session. He was kind enough to travel again down from Delhi to sit with us, teach us regarding the nuances of treatment of movement disorders, especially Parkinson's disease. With that, we'll go on to the history and timeline of the development of focused ultrasound. In 1880, the piezoelectric effect was discovered by Curie, and then we'll just straight away jump to 2016, where the first randomized trial for focused ultrasound telemotomy was published in the New England Journal of Medicine for essential tremor. You must know that as early as in 1950s itself, Fry and colleagues had discovered the effects of highly focused ultrasound, but that they did it by drilling burr holes, 2 burr holes in the frontal region, 2 burr holes in the occipital region, and then focusing ultrasound based on X-ray tomograms, and assessing the proximate area of the thalamus, and they did telemotomies with some success though. Next came radiofrequency ablation telemotomies, which was carried out in a large extent, especially in the Institute of Neurology in Chennai. And then with the advent of Syndopa, most of the surgical treatments of Parkinson's took a backseat. With the advent of Syndopa and its dopamine agonist, most of these surgical techniques took a backseat. Then came DBS, which was a revolution, a paradigm shift in the treatment of movement disorders, especially in Parkinson's disease. Though, and it is still one of the mainstays of surgical treatments of Parkinson's disease. When in 2000, early 2000, the first FUSA or focused ultrasound telemotomy was done, and then gradually it picked up. And the first clinical trial was published in 2016. The first clinical trial for Parkinson's was also published in the New England Journal of Medicine in 2016. Now, this is a mobile unit which gets attached to the MRI machine, a 3 Tesla MRI, and this is the transducer, a small helmet-shaped transducer. This is the frame, a routine stereotactic frame that fixes the patient's head to the transducer. The transducer contains about 1024 ultrasound elements, and each element emits an ultrasound ray of a frequency of about 650 kilohertz, roughly 650 kilohertz. And all these ultrasound waves are focused to one point, a particular point, with sub-millimeter precision, generating thermal energy and producing coagulation necrosis in that part of the brain. This is the external programmable power module that generates the power for developing the ultrasound. This is the external unit for storage of cold water. You need an interface for ultrasound to enter into the skull and into the brain. The interface is cold water here, which circulates around the head. It serves two purposes. One, it serves a purpose of interface, and second, it also serves as a medium through which the ultrasound waves can easily travel towards the skull, through the skull and into the brain. And this is how it occurs. Now, we've all, as children, focused lensed sun rays on a piece of paper, on a piece of cloth, and burnt a small hole in it. And it's the same, exactly the same technology being used here. Instead of focusing ultrasound or lensing sun rays, here we lens ultrasound waves into a particular part of the brain, especially the deep brain structures. In this case, the thalamus and the structures around the thalamus. And we must remember the words of Narabayashi, who was a neurologist, neurosurgeon, 1950s, who had said that all, if not most, movement disorders can be treated by lesioning structures in and around the thalamus. So movement disorders have been very fascinating. With the discovery of levodopa, it changed the way Parkinson's disease was treated. The next paradigm shift was deep brain stimulation, and lesioning surgeries have been in vogue for a long time. A game changer was introduced 10 to 8 years back, and this followed radio frequency ablation, which was highly successful. And the advantages of this procedure are, it is with sub-millimeter precision. There is no major complication. More than 10, 12,000 procedures have been done all over the world. Not a single major complication has been reported. Major complications is massive cerebral bleed or massive hemiparesis or anything like that. Infections, not a major complication, single major complication has been reported. Real-time monitoring during the procedure, which helps. Actually, the patient guides us to the target. There is no anesthesia involved, except for local anesthesia, 4-point local anesthesia to fix the frame. There is no incision, there is no blood loss, almost 100% effective, totally non-invasive, and the results are seen immediately on the table. To add to this, the tremor vanishes immediately after the procedure. Not only the tremor, the rigidity, the bradykinesia, they all also vanish immediately after the procedure. And due to its non-invasive nature, the whole process within 2 to 3 days. First day, we admit the patient for planning, and we get an MRI and a CT. A CT is to know the skull thickness and also to know the skull density ratio. Only if the skull is homogeneous, that is, the cortical and the cancellous bone are homogeneous, will it allow ultrasound to penetrate easily without much scatter. At present, it has been approved for essential tremor, not only for tremor dominant, but it's also been approved for all symptoms of Parkinson's disease and also for chronic neuropathic pain. The indications are expanding, I would say exploding, with new targets being identified for various problems. The GPI has been identified for rigidity, hypokinesia, PD, and proximal dystonias. Pallido-thalamic tract, which we are very much involved in, is also being worked up for the same purpose. In fact, lesioning the pallido-thalamic tract on one side relieves the patient of dyskinesias bilaterally. Various dystonias can also be treated by targeting the ventralis oralis nucleus, which is about 2-3 millimeter anterior to the ventralis intermedialis. The VIM nucleus is where we focus most of our attention, and it is a nucleus which is exactly in between this motor thalamus and the sensory thalamus. So the main function of the VIM nucleus is sensory motor integration in the thalamus. And these are the two charts which we rely upon. One is the Hassler chart and the Hirai and Jones. And you can see the VIM nucleus here, which corresponds to the ventralis lateralis posterior. And this, I will show you how we mark the coordinates. The VIM nucleus contains kinesthetic neurons somatotopically arranged along the medial lateral axis that correspond to contralateral muscles and joints. And I will not go into details of this picture, but I would focus your attention on this dentato-rubro-thalamo-cortical tract. Most of these fibers traverse the red nucleus after decussation and also traverse the VIM nucleus, especially at the tip of the VIM nucleus. The VIM nucleus is something like a comma shape, and it is broad superiorly and narrows down to a tip inferiorly. And the inferiormost portion of the VIM nucleus is where through these fibers either synapse or they just cross over to go to the contralateral motor cortex from the dentate nucleus. In essential tremor, tremor results from dysfunction of the inferior olive and the cerebellar nuclei. In contrast, tremor in Parkinson's disease is thought to emerge through a basal ganglia dysfunction, where increased activity of the inhibitory GABAergic neurons in the GPI projecting to the thalamus gives rise to rhythmic bursting activity of the thalamic neurons at tremor frequency. Whilst these projections, according to non-human primate studies, are primarily to the VO nucleus and not to the VIM, it is thought that the reticular nucleus potentiates these aberrant signals and relays them to other thalamic structures, specifically the VIM, via interneurons, where they are propagated to the motor and supplementary motor areas and may be modulated by the cerebellum. So the VIM, usually, whether it is an essential tremor or a tremor-dominant Parkinson's disease, or even voluntarily generated tremor, starts developing some fluctuations, and these lead to the generates oscillations, and these oscillations lead to the tremors. So whatever tremor, this can be controlled by lesioning the VIM, and not just the VIM. And as I will show you in further slides, both the VIM and VO complex. That's the ventralis oralis complex. Now this homunculus is very important when we decide, and as we go through the treatment of this patient, you can see the VIM nucleus, the homunculus lies like this from medial to lateral. If we need the leg tremor to be controlled, we go little posterior, inferior, and lateral. If we want the hand tremor to be controlled, we go again slightly inferior and lateral. If we want the jaw tremor to be controlled, we go a little more medially. We keep shifting the targets. As we do the procedure, we keep shifting the targets. If we have side effects, you may have sometimes burning sensation in the back. We shift the target anteriorly. If we have some others with numbness, especially burning sensation in the tongue and numbness on one half of the face, again, we know that we're going too posteriorly into the sensory thalamus. We shift the target more anteriorly. So it depends upon how the patient responds during the treatment that we keep shifting the targets in X, Y, and Z directions so that to achieve the best result for the patient. So though we initially select the target based upon the coordinates, X, Y's, and Z coordinates, it's ultimately the patient who guides us to the target. The patient guides us to the target. In a way, the patient is treating himself in this procedure. Let me not go into details of this procedure. We've finished 30 patients now and more than 33 patient schedules. The first patient with essential tremor we have done on both sides now, bilateral, because it's more than 7 months, 8 months since the first procedure was done. The second side was also done. The minimum time required is 4 months in various centers. FDA is approved 9 months for essential tremor. So it can be anywhere between 4 and 9 months. With this, I'll just show you 3 cases. But this is a 65-year-old gentleman, history of tremors not since childhood, sorry. For the past 15 years, his cousin also had tremors. His CREST score was 86, Quest score was 82. And this is how he was able to write. He was not able to write at all. He used to be a writer. He was not able to write at all. He used to just scribble. And he couldn't write a single word. This is how he eat. He's just simulating how he eats. He's never held a cup of coffee. He cannot drink he either drinks through a straw or somebody has to feed it. Tremor bilaterally, the tremor was more postural. It was also seen at rest at times. And this tremor, we first treated the dominant limb, and after 8 months, we treated the non-dominant limb also. So he used to be a writer, and he couldn't write. He could only scribble. This is how we mark the coordinates. This is an isotropic image. This is the image, isotropic image in which the DTI image has been superimposed so that we see the pyramidal tract very clearly. This is the globus pallidus externa, this is the globus pallidus interna, the third ventricle. And with these, we make targets. We initially start making these targets. We make 2 targets nowadays. Previously, we were making 3, 4 targets, one for the PTT, the pallidothalamic tract, and the other for what we have improvised nowadays from standard lesioning of targets of the VIM. We move slightly 1 or 2 millimeter anteriorly so that we include the VIM VO complex initially in our lesioning, especially for tremor dominant patients. And this was the patient he immediately wrote after the procedure, and the one who is not even able to put the pen on the paper is now able to draw an Archimedes spiral fairly accurately. From scribbling to drawing in just 2 to 3 hours. And this is him next day morning. He's never done this in his life for the past 10 to 15 years. He's never done a selfie in his life, and the first time he was happy to do a selfie. We've treated him on the other side also, and when we treat the other side, we are careful to place the lesion slightly asymmetrically. Anatomically, the VIM nucleus is 1.5 to 2 millimeter anterior on the right side and slightly posterior on the left side. When we did the left side, we decided to go a little more posterior so that we don't place symmetrical lesions, rather to avoid complications. This is a 62-year-old gentleman, 15 years, has been having tremors, predominantly in the left upper limb. His UPDRS score was 119, his PDQ score was 60, and you can see the DOPA PET, F-DOPA PET CT, which shows grossly reduced dopamine uptake, both the caudate as well as the posterior putamen, predominantly in the posterior putamen, which is very typical of Parkinson's disease. This is him showing the significant area of tremors. This is him as he's being MRI suit. This is how we mark the coordinates for the VIM VIVO nucleus. These are the calculations which we make on paper 1 day before. And this is him in the MRI console. And you can see the tremors. This is before the lesioning. And this is immediate. The tremors have completely disappeared, and he's doing well. Now, for the past 8 months, he's not had any tremors. He developed, of course, some rigidity and bradykinesia, for which we did another procedure on him, and we included the pallidothalamic tract. I'll also show you the pallidothalamic tract lesioning. And this is him in 1 hour after the procedure. 1 hour after the procedure, after having his dinner. He says he feels very good, not just better. The limb which has been shaking for years together now has completely stopped shaking. And these are the lesions. This is the VIM VIVO complex I was talking about. That's the internal capsule. Though these are just 2 to 3 millimeters away, we take extreme care. The procedure is very safe in the sense that we go for a first alignment phase, we verify, and then we treat low and only treat high. Only when we treat low and treat high do we produce a permanent lesion. When we go in the verifying stage itself, we will know whether the patient is improved in symptoms and also whether he has developed some side effects. If he has developed side effects, we move the targets based upon his response. And then we do the final lesioning only when the whole team is satisfied that the patient has improved completely without any side effects. These verification stages, the temperatures generated are less than 50 degrees, and temperatures less than 50 degrees Celsius do not cause permanent lesions in the brain. And temperatures above 50 degrees, we do it at least 3 times in the treat low or the treat high stage. And then when we see this on the intraoperative, this is the post-op MR. If we can see, we also do an intra-op MR, and we see a white lesion, that is T2 white lesion on the intraoperative MR. That is the time when we stop our lesioning further, and then we wind up the process. Now, this is another patient with advanced PD, a EPD score of 165. You can see the wheelchair. He cannot walk. He had significant tremors, both upper limbs and including the jaw, and severe bradykinesia. Also severe bradykinesia and also rigidity. And he was not able to walk without. And this was him after a single dose. Developed a severe levodopa-induced dyskinesias. He's been tried on all sorts of medications since 2014. He was also tried on an apomorphine infusion, apomorphine pump, which did not work for him. And these were the lesions. This is the pallido-thalamic tract lesion, which I was talking about. The pallido-thalamic tract lesion is carefully placed about 3 millimeter lateral, 3 to 4 millimeter lateral to the, you can see this small black dot, this is the mammillothalamic tract, and 3 to 4 millimeter medial to the internal capsule, which is here. This is the VIM-VIVO complex lesion, which is calculated in many ways. One of the ways of calculating is to look at the GPI posterior border and draw a line from here to here. Usually this is called the VIM line. We do our first lesioning 2 millimeter anterior to the VIM line. That is how we start. And then based upon the patient's response, the tremor response, we change the targets. Maybe we may go a little posterior, we may go a little medial. In this case, we went a little medial because he had a lot of jaw tremors. So initial lesioning, we did a little laterally for the hand tremor, and then we went 1 millimeter medial to abolish the jaw tremor also. The jaw tremor also disappeared. His dyskinesias also disappeared. Dyskinesias have disappeared bilaterally. Lesioning PTT disappears, takes away the dyskinesias bilaterally. Of course, most of the lesioning in US is targeting the globus pallidus interna here, but it's a slightly difficult target. You have to place 2 or 3 lesions in the GPI, and the visual fibers from the optic tract coats very closely to the GPI. So most of the times we result in create a lesioning of the optic radiation fibers, and hence you can have visual field defects. It's very close to the internal capsule, as you can see, and sometimes patients can have hemiparesis also. So hence we avoid the GPI totally. We go only to the this pallidothalamic tract, or as which was called previously and even now as the Forel's H1 field. You have H1, H2, H3 field of Forel. This is the Forel's H1 field, where the fasciculus lenticularis and the ansa lenticularis, the main pallidofugal outflow, which comes to the vivo nucleus of the thalamus, come here at this point. This is exactly at the ACPC plane. So this lesion is usually subthalamic. It's at the ACPC plane, midline, and usually around 8 to 9 millimeters from the midline. Usually, because the anatomical variations of various patients, we prefer to use the mammillothalamic tract, the internal capsule, and in the coronal Swan images, we mark out the subthalamic body, and we keep a distance of about 3 to 4 millimeters from all these 3 important structures. And then we create a small lesion, which is about, again, 3 to 4 millimeter in diameter. And that is how this is targeted. The targeting is relatively easy if we know the anatomy here properly, because this is a more medial target than the GPI. And this target benefits the patients bilaterally as compared to unilateral. The dyskinesias go off most often in on both the sides. And this is the patient. The patient immediately recovered. The patient was not able to walk, started the next day. He's doing fine. And about another 4 months' time, he's coming for the next lesioning also. With this, I would like to end the presentation. There are an umpteen number of cases, but I would not like to share all the cases. There's a case of dystonia, where we targeted the VIM complex. Leg tremors also vanished. And this patient had severe tremors, a school teacher who couldn't write on a board. And I told you it's a real time, and you can see how he wrote. He has written his name here, and I don't think anybody can figure out what he's written. And this is after the third sonication. This is after the fourth sonication. These are all during the initial phases. The fifth sonication, the seventh sonication, eighth sonication, and with the ninth sonication, he was able to write his name completely. One who could not even write anything, was just scribbling. His school teacher, now he's writing on. And this is what he wrote the next day. With this, I would like to end my presentation. So it's a boon for patients with movement disorders. And the results are seen immediately. It's a very safe procedure. It's totally non-invasive. And of course, you cannot expect all the symptoms to go away. Drugs are the cornerstone of treatment of Parkinson's disease. All these patients need to be on drugs also. However, over a period of 3 to 6 months, you can expect a 40 to 60% reduction in the dose of these drugs. And we all know that Parkinson's disease is progressive. So down the line, new symptoms might emerge in these patients also, but it makes a huge difference in the quality of life. Thank you, one and all, for patient hearing.
Yeah, Dr. Vijayan, that was a fantastic deliberation.
Thank you, sir.
I heard you before also, so it makes really very, very enlightening talk to me and everyone else. It is something like magic after DBS. I think this is one of the most phenomenal discovery in the field of, or maybe innovation in the field of movement disorder management sciences. Although, as we know, it is a technology that is in the driver's seat and science is the back seat. But I think this is one of the most important contribution to the management of movement disorders, as you have very nicely elaborated different aspects where exactly this can be used and what could be the limitation. However, there could be some questions, and if it is okay, Dr. Lakshmi, would you please take up those questions for him? Or
yes, sir. Yes, sir. Yes, sir.
Yeah.
Yeah, yes, sir. And before the Helisha has asked, can it be used for dystonic head tremors or FXS tremors? Can it be done bilaterally? Pros and cons versus DBS.
The only disadvantage that at present that it cannot be done bilaterally. But in cases of Parkinson's disease, there are reports from Switzerland where they have targeted bilateral pallidothalamic tract or the Forel's H1 field. That can be safely targeted bilaterally. If the patient's ventricle size, the volume of parenchyma, everything is good, the thalamic volume is all good, then they say that bilateral pallidothalamic tracts at the same sitting is possible, and they have documented also, they have done also. But that's not yet approved.
And Kayur Bush has asked about what is the cost?
The cost at present is 20 lakhs as a package for 3 days.
And there are no
Is there any
further.
Pardon, sir. Go ahead, please.
So there are no other questions, sir. Any other questions from the floor?
I was just wondering, hello,
Sir,
yeah. So, is there a single machine in India that is with you, or is there some other machine has already come?
at present, there is only one machine, sir, at Coimbatore.
Okay. And you said how many cases you have done?
We have finished 30 cases, predominantly Parkinson's. 20 of this has been Parkinson's disease, and we have finished 33 treatment schedules.
And just to recapitulate for young neurologists, it's mainly for the tremor prevention. But did you find any other score improvement in rigidity or bradykinesia?
Yes, sir. The rigidity and bradykinesia almost vanish with pallido-thalamic tract lesioning.
All right.
Thalamic tract lesioning produces improvement in all areas. Tremor less, of course. If the patient is left with tremor, we go on to the VOVIM complex also.
And Elias asked about dystonic head tremors. Do you think some different target listening?
The target for dystonia, proximal dystonia, is GPI, sir, which we have not attempted it, which is a very difficult target. The target for proximal dystonia is GPI. For distal dystonia, like writer's cramps, is V1 nucleus again.
Is there any target for generalized dystonia?
Again, GPI, sir. GPI is the target for generalized dystonia.
All right. So, Dr. Lakshmi, isn't it a magic or something really?
Sir, I went personally. I went personally and enjoyed the
right.
enjoyed the dramatic. Professor Vijayan was kind enough to invite me on one of his early cases. We went there, and I saw the dramatic relief, and I felt, in fact, the machine initially came they wanted to get it installed in Chennai. I was worried about whether I'll be able to break through the cost, 20 lakhs. And I was not comfortable taking such a huge risk. Whereas Madheshwaran, Professor Vijayan and their team, Arutselvan and all, they took the risk of establishing this machine there, and they're enjoying the fruits of the success. And kudos to, and it's a very, very dedicated team. So that I can assure you, because I saw all the entire team was spending with the patient for the 3 to 4 hours until all of them gets convinced. They do the sonification only after that. So I was amazed by the level of commitment, and my hearty congratulations to the entire team. And before I hand over the mic, next session is our 36th 3-year completion. Looking forward for a grand wish. All of you, please join on the last Friday, and we will have a grand show for all of you.
As we have promised, now we are adding this one more feature. So either some new treatment modality or some new investigation will incorporate. And coming back to Vijayan again, I have heard that these people are kind and quite understanding people. So maybe one can request properly. I think the hint is enough. I'm very happy to acknowledge that you have cured almost instantaneously our Sterling promoter's mother, and he is so happy that he wants to get one for us. Let's see. Thank you very much. So over to Mr. Chadda, and thanks again to Dr. Vijayan, Dr. Debashish and his full team, Dr. Lakshmi and all participants and colleagues and delegates. Thank you very much. Mr.
Thank you,
Chadda,
sir. Thank
please.
you. Today it's really a great day, as today there is 2 topics for the first time in the Secret of Neurology. And we are at the end of 35th session of Secret of Neurology. I, Arun Chadda, Associate Vice President on behalf of the Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in the last 35 months. And thanks to our course directors for such a beautiful changes they have done as the 2 topics in one day. And I would like to thank our honorable course director, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. And we are very thankful to young neurologist, Dr. Manju Yadav, for those who have presented the case today. Further to this, I would like to thank Dr. Ayush Mohan sir for clinical localization and differential diagnosis of the case. And I would like to thank Dr. Ashish Dugal sir for radiologically discussion of the case. And thanks to Professor Dr. Devashish Chaudhary sir, the director, professor, and the head of the Department of Neurology, GB Pant Institution of Postgraduate Medical Education and Research, New Delhi, for sharing their experience in this case and providing the important learning points and proceeding of this unique case. Further to this, I would like to thank Dr. K. Vijayan sir for presenting another beautiful topic. What is all this as far as the focused ultrasound? And both the presentation will be extremely helpful and informative to all the participants and all the DM and DNB students. Once again, thank you for your gracious presence. And it's been a pleasure being with all of you today. Thank you all for your presence. And we will meet again on 23rd June 2023 with yet another most awaited next session of Secret of Neurology. Till then, stay safe and take care. Thank you. Thank you very much, sir. Thank you, sir. Thank you.
Thank you. Good night.
Thank you so much.
Thank you, sir. Good night.
Ayush,
Good night.
Dr.
Thank you so much, sir.
Ayush,
Thank you.
Thank you. Thank you, Dr. Ayush. Thank you, Ashish,
Dr.
sir.